next speaker is Dr. Amit Pandey. He was my partner in crime at Center for Sight. He's now moved on to Muscat, Oman. His first talk is on complications of valve tubes. Amit.
So I'll be talking about, oh, this is not moving, okay, it's moving now. I'll be talking about complications of valved tubes. I'm going to skip all this because this has been covered. I'll be mainly talking about the AGV because that's the most common valve tube that we use. Indications have been covered. I'll directly jump to the complications. So you can have intraoperative or post-operative complications. Let us take one at a time. You can have a conjunctival buttonhole. So like in any filtration surgery, any glaucoma surgery, you have to handle the conjunctiva very gently without using those sharp tooth forceps, only blunt forceps, and maintain hydration to maintain the elasticity of the conjunctiva. And if you have a conjunctival buttonhole, you can do a conjunctival flap or a patch graft. You can also damage the valve by either over priming it. This is important. You should not over prime your valve because or you can damage the valve housing by touching or grasping the valve, the no touch zone that I'm shown here. If you do that, you will end up with a non-valved implant instead of a valved implant, and even without an occlusion of the tube. So day one you'll end up with an hypotony, shallow AC, and overfiltration. We can have a false passage because it's kind of a blind technique that we do when creating the needle tract for the tube. So what I would suggest is if you are putting it in the antechamber, be parallel to the iris, like Sir told, more towards the iris than towards the cornea. And also one trick is to always trim the tube after you have made the tract, because if you have a false passage, you have to make another passage and divert the tube there. So if your tube is short, you won't be able to do it. Over shortening of the tube can also happen. So what you need to do is you put the tube on the cornea and take 2 to 3 mm at least. I would suggest, if you are beginning with the surgery, to make it a little longer. You can always trim it shorter, but making a shorter tube longer would be difficult. That can also be done. I'll show you a tube extension as well. Post-operatively, you can have poor osmosis. That is usually because of the graft that we use. You have a white patch on the over the cornea. This is Totoplast, which is a scleral patch graft. With any scleral graft, you might see that poor osmosis. You can use corneal graft, like Sir told. I've shown this is a corneal stromal lenticule derived from smile surgery. I've used 2 or 3 to cover the tube. This is absolutely transparent, so gives very good osmosis. You can also use this U cord, which is an umbilical cord derived graft, which is also semi-transparent and not very costly. So this also gives good osmosis. Or you can do like shown in the previous videos. You can make a scleral tunnel and or a long tract, so that gives the best osmosis, I feel. If you have a tube retraction, what do? You can use this method. This is a 22 gauge angio catheter that I've used to extend the tube. This was tube retraction 2 weeks post-op. You cut the silicone tube, you use this angio catheter, dilate one end, put it in the stump of the silicone tube, and pass a ethylene suture through and through both the tubes to secure it in position. Trim the angio catheter and again dilate the other end and put the cut end of the silicone tube that you had cut initially. Make sure that only the silicone tube is entering the eye, because the angio catheter is probably not that biocompatible like a silicone tube. You can also use the cut end of a old AGV tube, that is called tube in tube technique. What if you have a long tube the other way around? This was a patient who had a flat anterior chamber. Probably the valve failed. This was 2 months after the surgery. He went to the gym and lifted some heavy weights and landed up with this kind of a flat AC, cataract, and a long tube in the AC. I'm sorry. So we ended up doing a cataract surgery. This is absolutely flat, so I had to just form the AC with some BSS first, and then once I got a little space, I made the side put a little bigger, and then with viscoelastic I could form the AC completely. Made the main port for the cataract surgery, and through the main port, using a Vana scissor and a micro access forceps, I could cut the tube a little shorter. I could trim the tube inside the antechamber itself. Completed the cataract. I'm not going to show that. And then I used this 40 ethylon to stent the tube itself. So 40 basically leaves a few microns around the suture for some amount of aqueous to drain. So if you have a valve failure or you have an overfiltering valve, you can use this. This goes in very easily. I'm using two micro access forceps to stent the tube. This patient did really well. He had 16 pressures with I think no medications post-operatively for a good amount of time. So yeah, you can also have a block tube by any of these: blood, silicone oil, vitreous, and iris. Also, hypertensive phase is something that we commonly see with valved tubes. This usually happens after a few weeks after the surgery, and basically the bleb around the plate is maturing, and because of that it takes a little time. So if you don't pay attention to that, you will have high pressures. We can manage it medically, and most of the patients, they do well with medications, usually topical medications if required. And digital massage plays a very important role in this this condition. And but even if with full medications they don't do well, or the tube fails, then you can do a needling with antimetabolites, which usually doesn't work with tubes, at least in my hands. Or you can do a revision, or you can place a second tube in the eye. These are a few patients that I had put a second tube. Tube exposure can happen, so you need to repair that. This is an inferior tube with a PK which exposed 3 times. I've used scleral patch graft, I've used a corneal patch graft. So in this case I used the corneal stromal lenticules derived from smile surgery. I used 4, and over that I've put a conjunctival autograft also. So for 5 layers. Initially she did well. She also had 2 tubes, so initially also she did well, but again this has exposed, and I've sent that patient to Vanita ma'am. And you can also have corneal decompensation. So this patient had a PCIOL in the AC and also a tube. I'll just take a little more time. I'll compensate for in my next talk. So we did a open sky tube shortening and removal of this this PCIOL in the AC. This decompensation was mostly because of the IOL rather than the tube, because the tube was well placed, not very long. But still I shortened it because I had the chance, so that it goes away from the graft area. It should be only in the host section. So that was an open sky shortening. Also you can have an infection endophthalmitis. Diplopia and squints are very rare with AGVs. The last thing that you might have to do is, in a painful blind eye, you might have to remove the implant. I'm removing an ADI here, but concept would remain the same. Yeah, so a lot of hemostasis, a lot of blunt and sharp dissection, because the tenions becomes very thick over the plate. You need to isolate the tube first and remove the tube from the AC first, and then you can basically release one edge of the tube, one edge of the plate from the side, and through that opening itself the entire plate might come out. Also there are holes on the implants which the fibrovascular tissue grows into, and you need to cut that to release the implant from the eye. This patient was a painful blind eye, but he did well after the surgery. Yeah, that's it from my side. Thank you so much.